patient with a history of breast cancer. We got follow-up just for, you know, she's been NED in the abdomen and pelvis. And so I guess maybe this is an imaging, I guess, you know, be a little careful, or let me see if hold on. I'm going to pause for a second so I can find my other images and show you the issue. Okay, that's okay. So when we know the cervix, what do you guys, what do you guys think about the cervix? Maybe I'll give you one that has better contrast. This one has better contrast enhancement.
Looks a little bulky.
It's a little plump, right? I think so too. And I guess, like, for me, it's more of like a, I don't know. So it was a little plump, and that was mentioned, and so then we got a.
Seems out of size proportion compared to the uterus.
Yes, agree with all of that. So I'm sort of curious to see what you guys would do. She has imaging dating back to, like maybe 3, 4, 5 years, and they've been all
always compare.
Stable. Yeah, exactly. Old as gold. So this is the one from, 4 or 5 years prior to the other one that I showed you.
And does this, Nelly, does this have a similar appearance on the other sequences? It's not just artifactual because of the way the sagittal section is being cut.
Oh, you're asking if we can, okay, so I'll show you the axials. So axials is a little, you can see the prominence as well, right there. Here's your axial. Okay, that's a thin. So let me give you the thicker slices, which right there. Okay, all right. So I showed you the 4 or 5 years prior. I'm just sort of curious to see what you guys would have all said in your report, to see.
So Manjil in the chat is saying should be amenable to direct visualization and physical exam, which sounds appropriate.
Okay, that's actually really good. So I'm going to, so the patient got an ultrasound, and it's, oh my goodness. So it's this. So it's just a giant Nabothean cyst corresponding to this finding. And I'm showing you this because I read the original study, and I commented that it was a little plump. And I feel like maybe I went down the wrong path of like excessive imaging order. Now I see what it's from, which is, a large Nabothean cyst causing that plumpness. And I'm sort of cautious about requesting more than is appropriate. And I'm not sure if I have a good sense of that yet.
I think that was reasonable because it didn't look like a classic just cyst on your CT. I think it was, and actually Steve said the same thing, does not look like a cyst on CT. A pelvic ultrasound I think is reasonable. The one that I was debating about with somebody recently was about like the endometrium on CT. And one of my friends from MGH said, they basically say at MGH, don't ever comment on the endometrium on CT because it can look thickened, but it's actually just like you're blending in with the junctional zone, et cetera. And you're going to order too many like pelvic ultrasounds. So that was one that we recently debated. Like if we think an endometrium looks thick on a CT, should we recommend a pelvic ultrasound?
Sometimes there's a mass there though.
I know. But a lot of times it does look weird. And then also another interesting thing I've seen is that the cervix can often look hypoenhancing compared to the uterus, and that's normal too.
I'm not sure about how practice differs from every place, but would suggesting a gynecology referral as a first step, because they are pretty good at examination and clinical, because sometimes these cancer patients they don't have any clinical symptoms, and that versus doing an examination. What would you guys prefer? like a radiological investigation versus a gynae referral?
Yeah, I mean, I think the gyne referral is great, but often like basically if we bring up something, they're going to get the imaging before they get the gyne referral or something.
Okay.
Hey guys, sorry I'm late. Hey Aarti. Yeah, you know, I feel like more often than not, this is sort of also the radiologist trying to make an amazing call on CT, you know, like.
I wasn't trying to
that,
make an amazing call, just,
you know,
it was more
I
out
do.
of equivocal.
Yeah, I'm always doing that. I'm like, you know, I'll tell you, I'll be honest, like I've described a cervical mass with parametrial invasion and all this crap, and then, you know, it turns out to be like cystosis, or to be like cervical intimal hyperplasia, or Nabothean cysts, or even a cervical fibroid. So, you know, I think at the end of the day, I agree with Amar, which is also like the GYN folks, you know, especially with pap smears and et cetera, like it's unlikely that anything distal to the mid cervix, to especially the external os, would be missed in this way. It's been my experience.
And I guess it's always nice to leverage our clinical colleagues, right? I mean, because we can't be driven by imaging, isolated imaging exam alone. So, and yeah, Steve said we need to pedal it softly and let them manage clinically. Okay, cool. Thanks for.
No, I was also going to say that, I mean, the findings of the ultrasound are helpful. She has this large Nabothean cyst, and I know we always just kind of, you know, poo-poo those, but they can cause pain.
It's true.
You know, there are the larger ones do cause problems, or they can.
Mm-hmm. That's a good point. So this next case, so there was an imaging study that, you know, comment on another area of plumpness, but this time in the pancreas. Here, what do you guys think?
Still looks fluffy to me.
Agreed.
It looks
And
like
no
dorsal
contour
ventral
deformity of the vessel.
It looks a bit different from the remaining parenchyma. It looks more like fluid density.
It looks
Yeah.
like
Yeah.
it kind of looks like dorsal ventral differentiation of the pancreas.
Who said that?
Gane.
Oh, God, you're brilliant.
I've not heard of that. That's interesting.
So then the report said there could be a mass. So recommended for the evaluation. So we got an MR. And here's the MR. So here's your TT. Let me know what you want.
Can you show me the in and outs too?
Yes. So here they are. Here's the in phase. And then I'm going to show you the out of post phase.
So it doesn't look like pseudomass from lipomatous infiltration, but it still looks fluffy with like normal fat interdigitating. So I would still say this looks normal.
Yeah, agreed. And you know, the contrast enhancement was very similar. Background parenchyma. There's nothing that, you know, there's no ductal dilatation. And so I think it's what Gane said. Manjil was asking if there's a time delay between the CT and MR. It was a delay of 2 months. What made you ask that?
I was just thinking on the off chance of like focal pancreatitis, or like
Oh, gotcha.
inferior group pancreatitis, but I mean the MRI looks so normal.
Yeah. So, you know, I remember when I was a training, like there was a pyramidal lobe, which I think is what Gane was referring to. It's just a lobulation. You know, we get that fishtail pancreas that I presented in the past case conference, where you can get fooled for, you know, focal mass, but it's just a fishtail pancreas, a congenital variation of the anatomy. And I think this is also another congenital variation. And when I was learning, we had called it a pyramidal lobe, but I was trying to Google it to, like, you know, verify that, and I wasn't able to verify it. So I like the dorsal ventral. What did you say, Gane?
Dorsal ventral differentiation of the pancreas.
Yeah, I like
think,
that better.
I don't know if I'm correct in this. I can Google it quickly, but I think it relates to the different blood supply and drainage that the unsnip process of the pancreas has compared to the rest of the pancreas. So similarly, how you can see focal fatty infiltration in the liver, you know, because there's different drainage patterns, you can also get the same thing in the pancreas, and it can simulate a mass.
Oh, okay, that's good to know.
But Gunay, in this case, you're saying that the differentiation is like we're seeing it as more focal because it's next to, like, I don't, to me, this just looks like a lobulation of the pancreas. Like, I don't understand what you mean by differentiation of the two.
Well, if you look at the unsnit process of the pancreas, it's better seen, I think, on the CT. Looks much more soft tissue density than the rest of the pancreas, which looks like, you know, more fatty infiltration of it. And so it's just differentiation in the amount of fatty infiltration of the pancreas. It looks like the, you know, part of the head and most of the body and tail are pretty fatty, whereas the unsnit process and part of the head are relatively sparse, and it can simulate a mass. And I think it's mostly just because they have different blood supply and drainages.
In this case, I would probably agree with Aarti. Like, to me, I think it's a lot, rather than, you know, one area having more soft tissue versus another, to me, it all looks similar in signal intensity. So I don't know if that precludes.
Look at the unsnit process in that, and then check out the CT. I think
here the unsnit process is somewhere here, maybe here.
Yeah, right in front of the
and then the
IVC.
CT. Okay, let me pull the CT. Does that help? So you're saying the unsnit process is more soft tissue density because it had the different drainage from the rest of the pancreas?
Correct. Yeah.
Does
that
this
tends
help?
to come from the SMA and SMV distribution, whereas the body and tail and part of the head come from the splenic artery and vein.
Okay. All right. I don't know if this is helping or not, but it's informative. Any comments, Aarti?
No, I think it's a great point in general. I'm not sure I'm convinced in this case, but I definitely have seen that where, like, you even can get like chronic pancreatitis in just the unsnit, not the rest, or, you know, or fatty infiltration one or the other. So great point.
Awesome.
Nelly, can you show the pre-T1, please? Pre-T1 fat sat.
Let me pull up the case again. 1 second. I'm sorry. I was moving on to the next case. Okay, so here is the original case, and you want pre-T1 fat sat here. Did that help?
Just seeing if there is any signal difference there, because this sequence really shows the, you know, the pancreatic substance.
Yeah.
But I think there are too many artifacts right over that area. So,
yeah.
So really doesn't help in this case.
Okay.
Thanks for doing it though.
All right, so this next case, this is a patient with a liver lesion. And I'm showing this because I've never seen one like this before. And I don't know that we can make this different. I mean, well, we'll see maybe. So here's your T2, T1. There's two. There's one there and then one right there. Diffusion. There's one there and then one up. So it restricts. Contrast enhancement here is arterial. It's enhancing. And then there. So we have multiphasic. And here's the delay.
Nelly, any demographics?
Demographics. What do you want to know? No history of chronic liver disease. No hepatitis B, not what?
Not a young female.
This is a female. And this female is, let's see if the patient's young or not.
Not that young.
Not that young.
50.
50. Thank you, Teresa. We read this case together.
I'm just guessing. But I remember her not being very young. But it's all relative.
Exactly, Teresa. Now I think 50 is young.
Right? As soon as I said that, I was like, oh.
Thank you.
I use that word with like a lot of caution, old and young, because I've had people like any age. I say, oh, do you think that is young? That is old. I am say X number, so I just say.
It's funny. All right, so Manjil was saying on OCP, no. And then Steve said not a lot of things. I don't know what that means, but okay. Anyways, I don't know that we can call this prospectively. This patient had biopsy, and it came back as a polytypic plasma cell inflammatory lesion with IgG iron deposition. So the IgG level wasn't super high. It was a little bit like higher, but not super high, like we would see with systemic IgG. So this was actually a mix of like various. They had IgG deposition. They also had a bunch of like other inflammatory deposition. So they couldn't really call this like IgG, but this was in sort of that spectrum, that category. The patient subsequently had. Oh, wait, give me a chance. Autoimmune related. Oh, sorry. I didn't. Manjil, autoimmune related.
That was
Steve
a joke.
said, wait. Oh. Okay, sorry. I was too focused on my case. Anywho, so the patient was treated with steroids, and this was the post-steroid imaging. So there's been, the lesions are less enhancing. They've decreased in size. And so they're going to continue until the patient resolves completely. So I don't know if, you know, if anyone else has any input, like, does this qualify as like one of those, you know, inflammatory pseudotumors that we can see in the liver? Or any other thoughts, Aarti?
Yeah, I think this is in the spectrum of inflammatory pseudotumor, and basically you're not going to get it without the diagnosis. So
cool. All right, so I'm gonna. Sorry, go ahead. Somebody else was saying something.
No, that's it.
Okay.
And it's improved after steroids.
Nice.
Yes.
And nothing else was involved, right? Like no other organs?
No, this was just a liver.
Wow.
Yeah.
That's
this is
unusual.
not like a specific or described appearance. Like retrospectively, there's nothing that, say, for example, if we get a case next time, there's no way that we can see this.
That's correct. Yeah, I don't know that we can call this prospectively without calling, without like, you can't exclude like malignant, right? Like lesions, for sure. Okay, cool. So this next case, it's a patient who had a Whipple and came in with abdominal pain and had all of this finding. So, and this is, patient had pancreatic cancer before, and so I had a Whipple remotely. I came in with abdominal pain, elevated LFTs. Prior imaging was normal. So then we saw this. So I wanted to show this case because I think this is a patient's white count was high. Like I said, LFTs were elevated from baseline, and then we saw all of this. So what would you guys have
Nelly,
called this?
we're only seeing like 2 images. Are you scrolling or?
I see.
I don't
have
know.
the coronal
it just
images
keeps kind of
pulled up.
skipping.
Oh, I think that's a Zoom thing.
Okay.
And I can want to fix that. But right now I'm showing a coronal.
Yeah, we see
face.
that.
Can you see that? Okay. So it's gonna skip. I think that's just like, that's just a function of, yeah, I can't.
Looks like a lot of like periportal enhancement, and then the bile duct is enhancing, and then that hepaticojejunostomy, like that loop looks like it's enhancing.
Yeah.
Right.
Right. Yeah, exactly.
So like cholangitis.
Yeah. So I think this is a really great case of that. The patient was subsequently treated with antibiotics and actually got much better. I mean, it's in this case, like to me, like that, the patient had this. I think this is a duo. Is that right? No. You're right. This is a cholangitis. So the loop of like bowel was also thickened. So it was like a combination of focal enteritis as well as cholangitis. And so the patient got treated with antibiotics and got better. The other reason I'm showing you this is because I'm always impressed by what our gastroenterology colleagues can do endoscopically. So this patient had pancreaticojejunostomy and anastomosis and had surgical revision because it caused complicated by, pancreatitis and whatnot. So they've been trying to manage this chronic stricture that this patient had. And so our GI colleagues, I can't believe they can do this. This is amazing to me. So he put a stent between the jejunum loop and the pancreas because it was dilated before, so to decompress this. Like, I didn't know they can do this. And so he has a stent in the stomach as well. So there's a stent going from the stomach into the pancreas, and then a stent going from the pancreas to the jejunum. So it's amazing to me, sort of the, like, you know, what they can do now endoscopically to try to decompress the pancreas. And I've seen other sort of aggressive interventions as well, which has really been impressive.
Nelly,
so,
that's amazing. I've never seen that.
Isn't that incredible?
So cool.
Yeah, like, I mean, apparently we have, like, our gastroenterologist here is like world renowned for doing these like incredible, you know, look, I mean, look at it, and it's amazing. Yeah.
Can we talk about the liver? I mean, it's kind of impressive. Is that all periductal enhancement?
I think so.
From cholangitis?
Yeah, I think so, because I'm going to show you the patient had a follow-up after antibiotics treatment, and it's all gone. Let me see, give me a pull arterial. So this is the post-antibiotic course.
So basically the stent is relieving the backflow from the pancreatic juices. Instead of the pancreatic juices like going into the pancreaticobiliary limb and up into the liver, that stent is now rerouting it down to that other jejunal loop. So everything else was able to be cooled off.
Yes. Yeah.
Cool.
Yeah, it's amazing. Okay, that's it for me.
Surprised there's not a risk of inducing pancreatitis when you try to pull off something like that.
There is.
There is a risk. They just got lucky. Manjil's next. Manjil has a case.
Hey guys, all right, let me try to figure out how to share my screen. Okay, sorry.
And we have that advanced function, so you can say share screen, and then instead of basic, go to the advanced, and you can just share a portion of your screen.
Okay, is that working?
We don't see anything yet.
Okay, let me try again.
You have to, and then you have to press share in the bottom right.
Oh, the case I read. I'll show you the case, you know, the series that I read. So this was a case of a patient who had a prior history of a nephrectomy for renal cell carcinoma, and this was clear cell type. And I was reading this follow-up. I'll show you the priors in a sec, and I'll just scroll through real quickly and show the findings here.
It looks like there's tumor invasion of the vein.
Yeah, there's definitely something in the vein, right?
Yeah.
The vein, you know, looked kind of gray, that thrombus to me, and it was expanded with some, you know, stranding around the vein itself. And then, you know, to my eye, it kind of led to this area that, you know, this partial nephrectomy was like 5 years ago. So in my head, I had thought that this should have collapsed, you know, contracted by now, and there was just too much soft tissue here in my brain compared to what I'm used to seeing for partial nephrectomies. You know, no invasion outside the renal capsule, no involvement of Gerotis fascia. The psoas looks good, just like really around these clips. Let me show you so this was the urothelial phase, and then here's the excretory phase of the same. And again, kind of this idea that there's this, you know, oblong triangular shaped soft tissue abnormality, and then of course the renal vein thrombus as well. So that was the CT. So then I started going back, and, you know, if we go to the MR enterography, this patient also has Crohn's disease. You know, we didn't call it because, you know, it's hard to see this kind of stuff on an MR, but, you know, on an enterography, when you're not really focused on that. But here's the thrombus on the enterography that was, you know, in retrospect, you can see it. It looks more bland to me here, but, you know, I think it's hard to say. And then here's that abnormality again within the kidney. I just want to bring up some of the, you know, the prior imaging. So here, this is from 2007, also surveillance seen for tumor. And here's that area. The renal vein at the time looked normal. There was no thrombus, you can see. And here's this abnormality within the kidney. Steve is saying too much tissue in the renal sinus. I agree with you. Here's this abnormality. And I just, you know, one big question I had about this was trying to make a connection with the vein, you know, like how is the vein involved? Is this tumor invading into the vein or what?
Yeah, I think this is a recurrence in the kidney that has now grown into the veins.
Yeah, so that's kind of what I said, and then I called it that, okay? And then the tumor thrombus made me really suspicious. You know, if you look at this one from 2017 and you scrutinize the image, just keep an eye on that little ball of area there. You know, you know, I don't know how well it transmits on the Zoom, but there is some weird continuity here with this abnormality and the vessel. Like it squiggles around here for a while. See that? Like it's kind of roundy. But if you look at the follow-up, my study that I read on the coronal in the same area, it's bigger. It's bigger. That, you know, that area is larger, and it still kind of communicates with the vein a little bit there. So then an MR was done. And this was like a case that generated a lot of interest in my group. So I wanted to show it here. So here's the MRI, and you can see in that area, like what's going on down there. To me, I kind of was like, you know, the renal vein thrombosis is very suspicious. Aarti saying tumor, I agreed with you.
Very
It
squiggly.
actually has like shreds and streaks, like what we see in tumor thrombus and HCC invading.
Yes. So like, is this even intravascular thrombus or not? You know, that's the question. And so anyway, so this went down a long conversation within our group about whether or not this could be an AV fistula or some sort of tangle of vessels leading to you know, a venous connection and then thrombus associated with that. I mean, interestingly enough, like if you look at the subtractions that are laid in that area, you know, when scrutinizing the vein there, it's hard to say, but I mean, there are portions of it that look black, but, you know, tangle of collaterals, you know, so some sense that there could be a fistula there, an AV fistula. Could that be surgically, you know, from post-operative, or could that be even from a prior biopsy in that area? But I don't know, like the shape of this was weird. Like we didn't find a discrete mass. Anyway, so we brought up that AV fistula idea, and this ended up going to fluoroscopy, to angio. And here's the angio. Yeah, Steve says do an angio. We did an angio. Here it is. You know, and there is some drainage here into the vein. I don't know if I'd call it early drainage, probably not. I mean, the whole kidney is like super nephrographic by then. But at this point, the IR person very astutely said, I don't think this is an AV fistula, and it's probably a mass. So they took this to surgery. Can you guys see the PowerPoint now? Mm-hmm. The image? And here's the resection. And it's kind of hard to make heads or tails here. I mean, there's certainly some abnormality within the kidney in that region, but no discrete mass. On section to section, this came back intravascular renal cell carcinoma involving the vein, the segmental vein, and then growing into the renal vein. So both is the answer. Teresa, when I saw you said both, and that's exactly right. So this is an underlying RCC, it is. But, you know, in our group, we went down this long path of this just being a benign AV fistula and leaving it as B. But I think in retrospect, the growth is worrisome. The shape of it and the soft tissue, you know, like you said, the effacement of the renal sinus is worrisome. And at the end of the day, this needed to go to angio, and angio did kind of solve the question. I mean, again, like you said, Aarti, this is sort of like that neovascularity around the vein, and you don't really see a tumor per se. But even the fact that it's growing, it was kind of the issue. I mean, one person in my group made a pretty compelling argument to me that was like, well, Manjil, this is just like an AV fistula in the arm. Like perhaps after a long time of shunting, it just grows. And I kind of went down that road for a while, and then I hedged on the report, and it came back RCC. So I thought I'd show it.
Manjil, I think even in your PowerPoint, can you the path?
Yeah, of course, please.
That that white stuff is the tumor.
Hold on, let me bring that back again.
But we had a super similar case, and it went back, and we were calling it like, it was so vascular that we were like, oh, it wasn't see that white stuff there on the left hand kidney?
Yep.
That stuff is all tumor.
I think so, but it's intravascular, Aarti. Like there was no dominant mass there. That's the thing. But yes,
I disagree. I think that nodule to begin with that you had years ago was a mass, and then it grew into and then by the end it was both in the kidney and in the vein.
I agree with that, Aarti, but like check out the MR though. Like what's up with this arterial phase then? Because like it's one of these nitises, I guess, is the mass.
No. Like all of that expansile thing in the lower pole and that expansile thing in the vein is all RCC, and it has a lot of neovascularity because that's what clear cell does.
Exactly. So they ended up measuring this tumor at 3 centimeters actually, with a large intravascular component. And so then you're exactly right. Like this is sort of like those squiggly vessels around, like, let's say intravascular HCC, or even just an HCC outright with a lot of neovascularity, angiogenesis, and shunting around it. So,
But we had a similar case too, and it was super avidly enhancing, and we're like, is this an AVM? And they ended up embolizing it, and in the end, it actually was an RCC that was a small one in the kidney, but mostly in the vein. So that can also...
Yeah, I guess like, you know, so what I like for me, I guess the answer is like follow your gut instinct, because I originally read this as tumor and then asked like, you know, so many people about it. And the second thing is, you know, that you can get shunting also with a tumor, obviously, a hypervascular tumor. So, you know, it's like you said, like you don't want this to go down the pathway of coiling a tumor either. You know what I mean? On the other hand, I mean, this is a pretty indolent tumor, right? Because like the prior was from 2017 and it's 2020. So it grew slowly over the course of 3 or 4 years, but you know, it's a good one. Steve says biopsy. I asked that and they were very hesitant because on imaging, there was no real landmark to biopsy. You know, I think by CT, you would have been able, now in retrospect, seeing that the whole thing is tumor, you could have targeted that whole soft tissue triangular abnormality.
But when you're considering something vascular, you might want to not biopsy.
That's why. That's exactly
why it's the angio.
Yeah, the angio is good for that.
Cool, thank you.
Yeah, of course.
So here's my first case, and this is a donated case from my fellow Omar. What do you guys think? So this is the terminal ileum here.
Crohn's disease.
There's like a diverticulosis and like inflammation around areas of...
Yeah, exactly. So this was actually extensive diverticulosis of the terminal ileum and diverticulitis. And it actually developed in just a few days because we had a CT a few days before that, and this all looked normal. So just a couple of points about, and Manjil was asking about contained rupture. No, and these were just big diverticula. So we just looked up a few points about small bowel diverticulitis. The most common one is going to be the duodenum. So duodenal diverticula are the most common small bowel diverticula, as we see all the time. And they can get impacted. They can have diverticulitis. And then in the rest of the small bowel, the whole thing is pretty rare. It's usually not congenital unless it's a Meckel's. It's thought to be due to impaction and kind of increased intraluminal pressure, just like in the colon. And this patient had other, tics, even though they were fairly young. So they're having maybe not enough fiber in their diet. That's also affecting their ileum. And that's all I can pretty much find about it. I didn't see it any. So when you get cecal or right colonic diverticulitis, that's more common in the Asian population. But this kind of small bowel diverticulitis is just equally distributed, and it's more in older patients. So, and they just got antibiotics, and then they got a follow-up CT, and it basically is resolving. So, okay, this is my next case. And this is an ultrasound, so I'm going to, again, try to do this gingerly. Okay. So what do you guys think about the liver in this case? I'll get to some better pictures. But so here's the liver.
Is that air in there, Aarti, or what's in there?
Yeah. So this was all concerning. And I was like, oh my God, there's extensive air. And we had a prior ultrasound 5 months prior, and there was no air there. So I said, this is very concerning and the patient was pretty sick. Okay, I'll have to get rid of that. And you can see they've actually had a gastric pull through. And there was a little bit of edema in this gastric pull through. We were wondering about the wall here. And then in the liver, you saw that ultrasound that had really looked like extensive, either probably portal venous gas. And then here we can confirm that there is portal venous gas as it's going in little branching patterns towards the periphery of the liver. But it's really not as extensive as that ultrasound. And it was only done a couple of hours afterwards. So I was kind of baffled, like what happened to all the portal venous gas, and then also what's causing it. And we looked around, we didn't see any gas in the SMV, we didn't see anything in the bowel. This gallbladder looked kind of compressed here. but with a mildly thickened and enhancing wall. So our biggest culprit, we were thinking about the stomach, and maybe that had flown through the left gastric into the liver, like it was ischemic and then had portal venous gas. What'd you say?
The posterior wall of the stomach looks a little irregular.
Yeah,
right
yeah.
there,
We were wondering
a
about
bit
this.
higher,
Hematosis.
and then the left pleural effusion, I guess, would be a little concerning.
Yep. Okay. So anyway, we thought about all of those things, and in the end, they got an EGD. They had mild gastritis, but there was no ischemia or perforation. And the main teaching point in my case is that ultrasound can actually be more sensitive for portal venous gas than CT can. And actually, I'm glad Gane's here. Are you still there, Gane?
Yeah. No, that's definitely been my experience as well. I mean, we've had cases where we've seen, I mean, it's clearly portal venous gas and the patient's sick and whatnot, and you do a CT right afterwards and you hardly see anything there, and sometimes you don't see anything there. So I think ultrasound is more sensitive for portal venous gas than CT is.
Yes, and actually, I think my fellow's reminding me that there's a beautiful cine where we saw. Do you guys see this? Like you can see that air moving around in the portal vein there.
Yes.
So yeah, it's almost like micro bubbles. So this is real air. If you see an ultrasound with this, believe it. If you get a CT to confirm, I always thought like CT, I don't know, I guess I'm not as much of an ultrasound expert. I thought CT would be like the confirmatory thing, but in fact, it can be less sensitive for small little microbubbles and air. And then another interesting part of this case was that they ended up getting a HIDA scan because they were still searching for like what's causing this patient's like leukocytosis and like, you know, and I was like, there's no way that this is cholecystitis because this gallbladder looks, you know, small and contracted. And their HIDA scan was positive. I'll show you the HIDA. So basically they read this as that there was filling of the CBD and the duodenum. There was no filling of the cystic duct. So this could be due to cystic duct obstruction or acute cholecystitis. The patient then went to the OR and had their gallbladder removed. And this came back chronic cholecystitis with hyalinizing cholecystitis. So a couple of points here. One, if you don't have luminal distension, it probably isn't acute cholecystitis, although in the setting of chronic inflammation, sometimes it doesn't distend. And then two, if you have a HIDA scan that does not show the cystic duct filling, it could be due to, they call it cystic duct obstruction, which means it could be acute or chronic. A couple of the things that they did, so in this case, they gave morphine. What morphine does is it contracts the sphincter of Oddi in a counterclockwise fashion and basically pushes duodenal juices back up into the gallbladder and tries to fill it that way. So they gave morphine and it still didn't fill, which still doesn't tell you if it's acute or chronic. And then the other thing they can do is kind of wait for longer. And if it eventually fills, then you know that it's chronic cholecystitis. So if you get a HIDA scan report saying cystic duct obstruction, that doesn't necessarily mean acute cholecystitis. It could be chronic from the chronic inflammation. And you want to put it together with the other picture, which I would have said, you know, in retrospect, like one, I wouldn't have called this acute cholecystitis to begin with, but in retrospect, I can see how it's probably chronic. It's got that enhancing wall. But it's a thin wall, so I can also see why it's hyalinizing cholecystitis, which is when you get fibrosis of the wall from chronic inflammation. So anyway,
taking it out actually helped.
What was the cause of the portal venous air?
No, we still don't know what the cause of the portal venous air is.
Because
I am
that's
not
usually
convinced
sinister,
it was
and
the
like whatever
gallbladder.
the conventional teaching is that like that's when like you see that in end stage bowel ischemia and.
Yeah, I mean, but his bowel was fine.
The stomach really doesn't look like it's enhancing though in the posterior wall.
Yeah, they went for EGD. They said mild gastritis. He's now discharged.
That's good. Good for the patient.
Aarti, do you think the location of the stomach up there is this? You said this is a pull through.
Yeah, it was for a benign esophageal stricture. So they did this partial esophagectomy with a gastric pull through.
And there's no chance this is like incarcerated up there or the neck is too narrow or something. It does kind of look
I mean,
like
we brought up all of this and they went for EGD.
Okay, makes sense.
Yeah. Okay. My next case is this one. So this is a patient who has this finding on their uterus. You guys all know what this is, right?
Yep. Adenomyosis?
Adenomyosis.
Yep. So florid adenomyosis, so massive expansion of the junctional zone, little cystic spaces from endometrial tissue in the, and then this was the patient just like 5 years prior. And so just to show you how much adenomyosis can progress, it's a lot bulkier and more expansile. The patient's having like very bulky symptoms, a lot of pain, a lot of bleeding. And so my interventional friend, we were reading this, and somebody was asking about fibroids and adenomyosis and any endometriosis. We did not see that. I can try to pull up some other sequences, but I was reading this and I was asking my IR colleague, like, oh, wow, like, and she was saying like, oh, she's like having to get transfusions and like, it's a lot, causing a lot of pain. And I said, oh, why don't we just take the uterus out? And, she's IR, so of course she wants to do a UFI. And I was like, maybe you should just take the uterus out. And then she said, well, no, Aarti, even if you have like, bad disease, we should try for UFI first, because taking a uterus out significantly increases your risk for cardiovascular disease, even if you leave your ovaries in. And so I didn't know this, so I thought it was interesting. I wanted to share with you guys. I found a paper about it, but basically, even if you leave the ovaries in and you take the uterus out, hysterectomy, they found, the University of Minnesota, like it was a longitudinal study, they found that patients, if you did this below the age of 35, they had a 4 to 6 times risk of developing CHF and a 4 times risk of developing coronary artery disease. And the
That's
two
crazy.
theories, yeah, it was crazy. I didn't realize that. And the two theories are that the uterine arteries and the vessels actually are having some collateral supply to the ovaries. So even if you leave the ovaries in, it's affecting the ovaries and increasing that cardiovascular risk. And the second theory is that the uterus itself is cardioprotective. So there's something that it's releasing that is cardioprotective. So, and Francesca says, yeah, that's true. Who knew? Teresa said, so wouldn't UFI cause the same issue? I think it doesn't, because, UFI, I can even pull up that paper for you guys. I pulled it up, but I'm always scared about switching my screens now. But the UFI, I think, is kind of almost like when you're doing a splenic artery embo, it doesn't kill off the organ, but it significantly decreases the flow. So maybe then I guess, and also we don't have longitudinal data on UFI, so maybe in the long term, UFI might show the same thing. So they are planning. And then the other important thing about this, if they're going for IR, you want to report if they have fibroids and if they have adenomyosis, because they use smaller embolization particles for adenomyosis than they do for fibroids. Okay, this is a case. What do you guys think is going on in the, do the guides know this? Still taking out a lot of uteri. Yeah, I mean, that paper that I've read came out in 2019. So I think we're probably going to get more information about it in the future. Okay, new case. What do you guys think is going on with this patient's aorta?
Very strange.
Not good.
Well, I'm kind of like not showing you the full picture. Okay, so.
Is there something in it? Like a
balloon
pump or?
Yeah, exactly. So this is a balloon pump. And then what do you guys think about this balloon pump? Do you think it looks good? Do you think it's appropriately placed? Do you know where it should be?
Isn't it supposed to be higher?
Hmm?
Yeah, it looks too low.
Yeah. So
Not
people are
supposed to
saying
be
too
across the
high, too low. Is it too high or too low?
It's too low.
Okay, good. Okay, so I do have a slide about this. Let me try to get it.
It's supposed to be thoracic, not abdominal, right?
Yes, exactly. So, let's see if okay, I lost my slide. Anyway, I'll just tell you guys. So this it's supposed to be basically between it's supposed to go from the descending aorta and then basically to above the celiac axis SMA level. And then the inflation of this balloon happens during diastole. And basically it's basically called a diastolic augmenter. So the balloon only inflates during diastole and then deflates during diastole. The purpose of that is that basically it will cause pumping of blood to the distal aorta. It actually decreases your left ventricular afterload, and it increases your coronary artery perfusion, which only happens during diastole. So let me try to show you guys maybe like a chest x-ray for this patient. So the thing you might only see on a chest x-ray is, for example, this little marker here. This little marker shows you where the top of the pump is. And so the top of the pump should be below where you think the subclavian artery is coming off, so that it doesn't block off the subclavian artery. And the bottom of it should actually be above, like basically up here above where you think the SMA is taking off. So if we go back to my CT, this is definitely too low. It's going across where the renal arteries are taking off, where the SMA has already taken off. So they had to retract this balloon pump. And on the bottom of it, it has another little metallic marker. So that metallic marker should be up higher in the upper abdomen. I can't really see it on the scalp, but okay. Any questions there? Okay, this is my last case. This patient has obviously severe bilbil and pancreatic ductal dilatation. And the pancreatic duct is extruding into this large cyst. So what do you guys think this is?
An IPMN?
Yeah, it's a good thought. You could think about an IPMN. And that's kind of what we were thinking, like, is this an IPMN or is this some kind of disruption of the duct? And this is where CT can be really complementary. So this is the CT scan on the same patient. And you can see that basically there's extensive parenchymal calcification. So we've got chronic pancreatitis here. And this was a patient with known chronic pancreatitis and then this large extravasation. And they actually had like a hematoma, like hemorrhage within a pseudocyst, and they ended up getting like GDA coiling. And this was the leftover hematoma here. So I just want to show you the follow-up exam as well. Okay, here's the follow-up. And couple of things on this follow-up. Now we can see they've still got severe bilbil, severe pancreatic dilatation, but our pseudocyst has now decreased in size. So it was just a pseudocyst that was communicating with the pancreatic duct. And then here you can see that there's like a cyst here and thickening of the groove. And you always want to look very carefully in these kind of cases for an underlying pancreatic cancer. So here we've got our double duct, our small little, now smaller pseudocyst, and all of these like little side branches are dilated, but we didn't see a hypoenhancing area to say that there was also a pancreatic adeno. And the one thing that I also brought up here was that we've kind of got this hypoenhancing thickening of the groove and this cyst in the groove. So also brought up possible groove pancreatitis as one of the causes of this chronic pancreatitis. So take home point is that and especially when you have this kind of like ratty irregular duct, that's a little bit less for like a main duct IPMN. A CT can really be helpful. And if you see all those calcifications, you can think about like chronic pancreatitis. And then if you see thickening in the groove and a cystic space and thickening of the duodenum, those are all signs of possibly groove pancreatitis, which can just lead to chronic bouts of pancreatitis. Okay, that's it for me.
I have a great companion gyne case.
I have a, oh.
Oh, go ahead. I'll present next week. Go.
Oh, I just have a quick case.
Okay, go.
Oh, shoot. Okay. History is withheld. So it was for abdominal pain. Is anyone talking? I can't hear anything.
No, we're
No.
mesmerized.
We're trying to figure out where to look.
Oh, okay, well,
Like the
look,
left upper quadrant looks a little weird. Yeah.
in
Can you
this
scroll down?
area.
There, right there. There's. It looks something. Some.
Okay,
It's my eyes.
so some of the small bowel loops are tethered.
Yeah. And
See all
like,
this-
yeah, and there's like this fluid. Is that small bowel?
yeah, so this is all small bowel here. So
Mm.
basically there's, this stellate lesion kind of tethering the small bowel.
That stellate lesion has like a cyst or a duct in it.
Right, so there's tiny little cysts.
Ectopic pancreas.
Also, no.
Omar was asking about a paraduodenal hernia and then said never mind. So I don't know, I'm thinking like in the sclerosing mesenteritis spectrum.
Is there something in the right lower quadrant bowel, like here, or
Yeah,
is that just?
I don't know. Don't worry about it.
Oh no, that's like a pseudomass from succus
I want you guys
from
to
the TI.
figure out what is causing this.
Carcinoids can show you that sometimes.
Why does it have that cystic stuff?
Is it endometriosis?
Oh, that's a good thought.
Bingo.
And you
This
need to-
patient has had a history of severe endometriosis, stage 4. Apparently, I actually don't know the stages, but that's the worst. And she's had severe abdominal pain and has come in for imaging, and this is what we found. So you can see all
Good
these.
job.
These are the cystic endometriotic implants, and then this is the DIE with the tethering of the bowel loops. I don't see any intraluminal extension, which is something they always want to know, but I would assume with this degree of craziness that they are going to have to do some bowel resections anyways, which means they usually call general surgery to come in and help.
Were there T1 bright spots in that mesentery?
I don't think there were. Let me double check. Oh, and this, I think.
Do you have like a T1?
Yeah, sorry. The only reason I was showing this is that there's all this artifact on the bowel surface, and I think this is all from prior surgeries where they've scraped off endometriosis. That was my thought.
Oh, that's
here. Cool. I mean, some of it's obviously gas, but sorry, I had it set up. This is our pre-contrast. So right in here, I don't see any super bright T1 foci.
Yeah.
But I think the cystic components are pretty consistent with the
Whenever I've
cystic.
seen like these odd locations for endometriosis, like one thing which we were discussing, like T1 hyperintensity, that's one thing. And the other thing which I've seen very frequently are these cystic areas like adenomyosis, even endometriosis, and all these, say, cesarean scar endometriosis, those cystic spaces because of repeated bleeding and cystic changes. That's something that I've seen very commonly.
But we don't always see T1 hyperintensity, right? Like deep infiltrating.
Not always.
No.
Endometriosis is not T1 hyper.
I feel like what I look for is first I look for T1, and then I look for this, T2 dark kind of stellate scarring, and then I also look for any areas of tiny cystic foci. I mean, it doesn't have to be all together, but like those are kind of the three things I generally realize, that I kind of hone in on.
That's a great pickup.
You're an expert, like Nicole Hinman.
Kadar also had a case. I don't know. Do you guys, Kadar, I don't want to make you rush. Is it a quick one or do you want to wait till next time?
I can do it next time. No problem.
Okay. Sorry. Forgot.
No problem at all.
Okay. I'm going to end recording because